Hello, my name is Gerhard Hesse. I'm a Rolfer since 2084 and Rolfing instructor since 2007. This unit is about the tilt and the shift of the pelvis, and they influence, especially to our knees and to our gait. The pelvis, as the main segment to transfer the weight from the upper body to the legs and to the feet, may shift anterior or shift posterior. Shift means that the gravity center of the pelvis in the anterior shift is anterior to the thorax and to the lateral malleolus of the feet. In a posterior shift, it is posterior. Then the pelvis may tilt. Anterior tilt means, per definition, the spina iliaca anterior superior are anterior to the pubic bone. In a posterior tilt, the spina iliaca anterior superior are posterior to the pubic bone. Beside this, the pelvis can rotate. In almost every human being, the pelvis is rotated right anterior. Beside these intersegmental movements, situations, the pelvis does intrasegmentally, with each step we do with an extended hip joint, a torsion. The side of the extended leg moves downward. When Ida Rolf started to develop her method of structural integration, later more known with the name of Rolfing, most people coming to her looking for help had a posterior shift and an anterior tilt, a strong anterior tilt, a hyperlordosis. So she did very well in bringing these segments more in a line so that gravity supports the body. A couple of years after Ida passed, Jan Sultan, a former Rolfing instructor, came very clear with the idea that we do not have only this anterior tilt, posterior shift situation, but with some people we have this posterior shift, anterior tilt. And for these people we need a completely different approach to bring the segments in alignment. And again, a decade later, Hans Fleury, a former Swiss Rolfing instructor, thought it very logically through. If we do have a shift and a tilt, anterior and posterior, means we will have four basic types. So we have this, what he called regular, when the tilt is in the opposite direction of the shift. That means we have a posterior shift with an anterior tilt, a regular internal. An anterior shift with a posterior tilt, a regular external. And then we have these what we call symmetrical ones, posterior shift with posterior tilt, anterior shift with anterior tilt. And with some subtypes, as we will see a little on. Why internal, why external? When the pelvis goes in a posterior tilt, the femur rotates externally. When the pelvis goes in an anterior tilt, the femur rotates internally. This rotation that happens in the femur by tilting the pelvis is due to this double oblique situation of the acetabulum in the pelvis. So we have this from superior to inferior and from anterior to posterior. And to the very strong iliofemoral ligament you see here on this PowerPoint. Okay, let's do it. So you stand here and just in normal stance, and now you tilt your pelvis anterior and tilt it, a bit more please, tilt a bit more, and you feel how the femur rotates internal. Let go. Now you tilt your pelvis posterior, 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 and you feel how your femur rotates external. That's why the name internal and external come into being in relation to the tilt. And again, one decade later, Hubert Godard, a French Rolfing instructor, came with a very, very clear insight that we do not only have to look to the support system, how the feet and the legs are in a aligned situation, but we have to look also where we put our thorax or our head. So this will create a lot of dysfunctional descending lines. And this is not only mechanical, this is really where we are, where I put myself. Here always emphasis, we have to orient in space, open up in space. And space is not empty. There's a whole other human beings in there. That where I put my thorax, no, I say it from here, this will have a completely different situation for the pelvis and the legs than when I'm here, with my thorax here. So we have to look how we put ourselves, G prime, in gravity, where we put the head. Now many people sitting all day, head is anterior. This brings the pelvis in an anterior shift, thorax in a posterior tilt. So we don't have to look only to the leg and the feet. So yes, we really do need good support system, but as well we need very clear space orientation. Before we go to the typology, let's have a look at some anatomical aspects. If you look at the human body, the skeletal human body, we find that what we call a 5 lordosis system. So the cervical spine is a lordosis, the lumbar spine, the knee, the arches under the foot, and the space under the toes are a lordosis, embedded in kyphosis. The occiput, the sacrum, our calcaneus, the ball of our toes, and the end bone of our toes. Kyphosis. All the kyphosis exist out of one bone, except the thoracic spine, 12 bones. Generally, we can say that we walk by increasing the lordosis and then coming back to normal. We walk by increasing the lordosis, the knee, and then coming back to normal. The kyphosis serve for stability, the lordosis for mobility. And stability has to precede movement. This is very important. Most of the myofascial action we do, balancing on 3 little spots on our feet, is to stop unwished movement, not to fall. And only 20% is for the actual motion. It's not so much. So stability really has to precede. So if you look at the lumbar spine, we find the facet joints in a sagittal plane. This allows only 1 degree of rotation in between 2 vertebrae. And the dorsal or thoracic spine, the facet joints are on the frontal plane, easy rotating. Generally, we can say that problems that occur most often in the lordosis, in the cervical spine, in the lumbar, and the knees, are not rooted, these problems, in these segments, but come from a dysfunctional, often spatial misalignment of the kyphosis above and below. If they are not fitting well together, the dorsal spine and the occiput, the cervical spine will create a problem. If the thoracic spine and the position of the pelvis is not good, the lumbar creates a problem. So let us first have a look to the bony situation in the knee. So the tibia. The tibia find on the medial side, on the medial plateau, we find a very clear concave surface. On the lateral side, where the fibula comes, it's more convex. So obviously the knee is not only made for flexion extension, but also for some rotation. So let's have a look to the menisci. When we look in a standing position, straight leg, we see that the medial meniscus has wide origins and is fixated with the collateral ligament at the medial side. So hardly any motion. While the lateral meniscus, very close origins, no fixations at the lateral side. So when we flex our knee, when we bend our knee, the lateral meniscus moves a lot to the posterior, and here popliteus plays a very important role to pull it back, that it's not squeezed in this motion. But he has this capacity, the lateral meniscus. So again, here we see the knee in a flex situation. The lateral meniscus is quite posterior, yes. Now, when we do an external rotation, and we can do about 30 to 40 degrees external rotation, the lateral meniscus moves anterior again. When you do an internal rotation with the tibia, only possible 10 degrees, and this will become important later on to understand how pelvic shift influences, yes, moves back again. So the menisci are only possible in a certain range of motion. The rotation is very clear. 34 degrees external, only 10 degrees internal. So here in this picture we see really structures all around the knee. We see 20 and more stabilizers for the knee. There's no other joint in the body which is stabilized in this way. And definitely it has to be, because 2 long bones, almost the whole weight on the body, so when I load it, it has to be stabilized. And it would be very interesting to look in which moment of walking, which moment of gait, which of these structures in the eccentric, concentric, or the isometric action. but that would be another job. So if you look to this really surrounding stabilizing, we understand that if there's a misalignment in the situation, it has traumatic follow-ups. So if we look further down, we look to the talus, where the malleolus fork, so tibia and fibula, ending on the talus, we see that anterior, the diameter of the talus is wider than posterior. This has a big consequence when we do a dorsiflexion. So when we do a dorsiflexion, what happens with each step when we work with an extension in the hip joint, yes? The lateral malleolus should be spread apart, but this is not possible because these ligaments are really holding it tight. So what happens is, the moment we come anterior, the fibula moves a bit cranial, about 4 or 5 millimeters. But under here, the fibula sits here, under the tibia, it cannot move cranial. So with each step, the fibula undergoes a torsion. Here it's moved up, here the fibula, head of the fibula rotates. For this to happen, it really needs elastic but yet stable ligaments and a good, resilient interosseous membrane, not too stiff but not too loose. On the lateral side of the fibula, we find peroneus longus, peroneus brevis. Also touching at the fibula is tibialis posterior, going to the foot, to the beginning of the foot, and flexor hallucis longus. Upwards, only biceps femoris. When we are learning walking, we are not walking mechanically. Our body learns to walk with feet forward. The moment I'm in a dorsiflexion, these ligaments are stretched. The next moment, and this information goes to my soleus, soleus has to fire. So when there's a stretch, for example, a permanent stretch in the hamstrings and biceps femoris, head of the fibula is always taut. Ligaments and the lateral malleolus are stretched. Soleus is permanently on firing. So how can we get relaxed soleus if biceps femoris is always under tension? But now we're very close to the full chain. Flexor hallucis longus, in this moment when you lift the knee, is stretched. This information goes to biceps femoris, and biceps femoris, most of the fiber of the tendon of biceps femoris are not going to the ischiotuber, but becoming the sacrotuberous ligament. And this sacrotuberous ligament is the beginning of this fascia thoracolumbalis, covering, entering all the layers of the back, even with via latissimus dorsi to the hand. So there's a kinetic chain from the big toe to our hands. And it can only be working, when walking, when we are really having this situation. No hallux rigitus, tibetalar gliding, extension in the hip joint, means internal rotation, and so on. Thank you. Okay, let's go to the typology. As I said before, most people come in our office or in our practice now are not regular internals anymore, but regular externals, with the anterior shift and the posterior tilt. Maybe also due to this overwhelming sitting we are doing. Anyhow, so in the external regular, the lumbar lordosis is short. The pelvis is shifted anterior to posterior, the femur is external rotated, the tibia is internal rotated. The foot arches are low. The first metatarsal goes towards the big toe. They walk very clear, definitely, with ground. They swing the lower leg forward. Often the head is too much anterior by sitting on a computer. Yes? Or the thorax is swayed back for whatever reasons. Yes? In these external regulars, we cannot expect a big hip extension or a big tibia-talar glide or a toe hinge action, because the contralateral rotation of the spine is very reduced. So they are more in a static situation. Internal regular, we have a posterior shift and the anterior tilt. Means the lumbar spine comes in a nice curve. Very often we find it really elongated up in the thoracic spine, very nicely. The head is more in space orientation. Quite often it's a good alignment on the lateral side. The femur is the pelvis shift posterior to anterior, the femur is rotated internal, the tibia external, we have high arches. So here we really expect a good toe hinge, a good tibia-talar glide, hip extension, all these things. Yes. In some kinds, yes, of internal regular, the psoas or ligus or rectus femoris, hip flexors, are too tight. Then they come in a hyperlordosis and the knee starts to bend. That was the type when Ida Rolf saw a lot of these people coming to her. They're not so often anymore. So again, let's have a look to the knee. We have O-bowed and X-shaped legs. Even they look opposite, how they come into being is a completely different story. So first looks to this X-shaped leg. Usually this happens with a regular external, anterior shift, posterior tilt. Having a big belly, the pelvis tilts as much posterior as it can. The femur rotates strongly external. The arches go down, but as the tibia can only rotate 10 degrees internal, and it needs more, then happens a medial shift of the knee, and we have an X-shaped leg. So this is a rotational pattern. The X-shaped leg is also called genu valga, like hallux valgus, gena valgina, genu valga. Sometimes it is caused by the angle of the neck to the shaft of the femur. So here we can say that coxa vara creates a genu valga, and the coxa valga creates the genu vara. Genu vara is the O-bowed. So if the rotational patterns are not fitting to this existing X-shaped or O-bowed leg, we have to have some X-rays to see what's going on. Let's have a look to the O-bowed leg. In an O-bowed leg, femur and tibia are rotated in the same direction. That means we have internal O-bowed legs and external O-bowed legs, but both are O-bowed. So when the femur and the tibia rotates both internal, this happens very often if you're habitually sitting on your lower legs and the lower leg is rotated internal strong. Very, very often in Asian people. And you don't see it, but if you feel the spina iliaca anterior in relation to the pubic bone, you feel an anterior tilt. Anterior tilt internal and sitting habitually on the forelegs and the lower legs, internal rotation of tibia, internal, O-bowed leg. External O-bowed legs does not appear so often. When people wearing from childhood on insoles bringing the tibia in an external rotation and they have a posterior tilt, we have an XX O-bowed leg. So the external O-bowed leg, we don't find it so often, but we find it, and it's good to know what to do to understand it. And again, I want to say that if these rotational patterns are not fitting to the X or O-shaped leg, we have to get some X-rays. Maybe a pathology or coxa vara is causing this O or X-shaped leg situation. But another thing is very important to say. Both regulars, internal or external, if they're not too strong, they are good, they're okay. The external is more for stability, the internal is more regulars, more for dynamic, for mobility. We want to teach and help our clients to use both patterns, because that's what we do in walking. We go from an X to an internal rotation. But we prefer the internal ones, regular internal. But if we teach them and bring them to bring the pelvis back and anterior tilt, open the spine into space, and we don't bring the arches up, they will end a couple of years later in O-bowed legs. So we have to help them with our work, and they have to do a lot of exercise to bring the arches up. Congruency is very, very important. Both primary directions, some people are tend to have more internal space orientation, some are external ground orientation as resource, and this is good so. It's different with the symmetrical ones. Okay, let's go to the symmetrical ones. First, the external symmetrical. So the pelvis is shifted posterior and tilt posterior. So just do it. Move here, shift your pelvis posterior, tilt it posterior, and you will feel that your knees will bend. The lordosis is completely taken away of the lumbar spine. So the next lordosis, the knee, is strongly increased. Here we really need to work a lot for opening the space down here, space orientation, that they can use the crown. Their resource is crown, but they cannot use it because they're hanging in this situation. So usually with the external symmetrical, the head is anterior, the thorax spine is very, very straight, the lordosis is long and very flat, the pelvis is shifted posterior, tilt posterior, femur's rotated external, tibia's rotated internal, and foot arches are more or less okay. And they walk with femur and always walking with bent knees. Never straighten their knees, they cannot. So I would say then resources hindered ground. So now let's go to the symmetrical internals. We cannot do it because the tendons of our hamstrings and popliteus is hindering the hyperextension of the knee. Usually we cannot do it. So yeah. There, the pelvis is shifted anterior and tilt anterior. Sometimes the tilt is not so clear to be seen because it's so much anterior tilted. So this kyphosis, the lumbar kyphosis, disappears completely, the sacral kyphosis. So the knee becomes kyphosis, the next segment. This creates a lot of instability. Yes. One type of these hyperextended knees or internal symmetrical types is trained. We find it most often with girls who did a lot of ballet when they were kids, too early. Yes, they always stretch the knees. And if the knee is not giving a stability, the pelvis shifts anterior. Their lordosis is very, very up the whole spine, even the thoracal lordosis. Thoracal spine is interlordosis, up to the transition of the neck to the thorax. They have very clear space orientation. Space is everything. They're really going up there. So we have to bring curves in the spine. We have to reduce this hyperextension of the knees. What they have to do exercises. We cannot do it only on the table. They have to do a lot of exercises to strengthen certain structures and stretch other ones. That really takes quite a while. Usually they understand and they do it by themselves very easy and fast. Not so the other type of symmetrical internals. The down situation, the pelvis is shifted anterior, tilt anterior, the knees are on hyperextension, that looks the same. But their kyphosis is sunken completely down, reaching down to the L2, L3, sometimes L4. So this sacrum, this kyphosis is completely disappearing. The thoracic kyphosis goes down, down, down. The sacral kyphosis is away. The knee becomes the next kyphosis. So the alternation of kyphosis and lordosis is not giving anymore. This is a little more difficult to work. They will help and they will do in this support system, but along the lumbar spine, pancreas often led to this deep reaction on the ligaments along the lumbar spine. So this is a long time, deep work also, with a lot of emotional processing, usually to be said. Good. So this typology may really help you to find a good way to address the problems in your client, to help your client to come into a better structural situation. But don't put them in boxes. If the shift and tilt is small, yes, let them be. Just help them to be much more in space and find the space inside the heart, and to open all this. And beside this cortical, visual analysis, most important when you give a good session is our touch, our listening, what the body is needing. Thank you.